Good afternoon, everyone, and welcome to today's interesting session. I might give people just a minute or two longer to join, and then we'll start the session. Okay, everyone, welcome again to today's session. And thank you very much to the Hematology Deep Dive organizers for inviting me to chair this session. We're looking forward to a very interesting talk given by Dr. Jenny Vaughan, covering the aspects of diffuse large B-cell lymphoma in Johannesburg. So before we start, I'm struggling. Oh, there we go. It's just a little bit slow to move. Sorry, before we start, just to cover one or two housekeeping notes. So after the session, recordings may be found on the bloodassayorganisation.za under resources for deep dive. If you do have any questions during the talk, please add them to our comments or to the chat box, and we'll keep record of those. If you do want to be added to the emailing list, or if you know anybody who does, if you could kindly email Milani at UCT. CPD points will be automatically submitted for each attendee. So please do ensure that you're using your own account. And if you need a CPD certificate, you could also get hold of Melanie Davids. And in terms of feedback, we do value your honest feedback, or the organizers value your honest feedback. If you would be able to complete the anonymous feedback survey at the end of the meeting, so there won't be any response to any comments made because it is anonymous. In terms of upcoming conferences, just to take note that the 16th Annual Hematology Oncology Symposium will be taking place from the 13th to the 15th of September in Cape Town for anybody who would be interested in attending, and there's more information on the website. Then this is the management team. So just to thank everybody in the management team for organizing these sessions, highly educational and very informative sessions. And now if we can maybe move on to welcoming our speaker, Dr. Jennifer Vaughan, who's going to give us a talk today on aspects of diffuse large B-cell lymphoma in Johannesburg, which is part of her PhD project. So if I can just tell you a little bit about, I'm sure she needs a very little introduction, but she's a hematopathologist based at Chris Hani Baragwanath Academic Hospital. She's been there for 11 years and has a wide range of interests in hematology, but particularly in leukemia and lymphoma diagnostics. And her PhD is looking at aspects of the tumor microenvironment, in particular in diffuse large B-cell lymphoma in Johannesburg. So thank you again for attending, and I'll hand you over to Dr. Vaughan to start the session.
Thank you very much, Tracy, for that kind introduction. Can I please confirm that you can see my screen and you can hear me?
Yes, I can.
Okay, great. Thank you to everyone for coming today and to the organizers for giving me this platform to present the results of my research. So I think, as we all pretty much know in this audience, diffuse large B-cell lymphoma is a heterogeneous form of high-grade non-Hodgkin lymphoma. And it constitutes the most common form of non-Hodgkin lymphoma worldwide, as well as among people living with HIV. At the heart of its pathogenesis in most instances are errors introduced during the processes of somatic hypermutation and class switch recombination, which are natural processes in B-cell maturation, which introduce errors into the genome in the effort to improve avidity of antibodies to antigen. So these form points of vulnerability for introduction of errors, which can be deleterious. These result in abnormal activation of B-cell receptor signaling, a constitutive activation of PI3, the PI3 kinase ACT pathway, the NF-kappa B pathway. As you can hear, I'm at home with my dog. Sorry about that. BCL6 and BCL2 inhibition or dysregulation, and EZH2 activation. So somatic hypermutation and class switch recombination, which introduce errors into the genome, particularly cause these mutations or translocations involving some of these genes. And this results in aberrant activation of these pathways, which results in cellular proliferation, differentiation arrest, and eventually emergence of a tumor. And this is further exacerbated by mutations which cause the tumor cells to evade the immune system. Immune evasion is further exacerbated in people living with HIV due to underlying immunodeficiency. People with HIV are also prone to developing infections from oncogenic viruses like Epstein-Barr virus and Kaposi sarcoma herpes virus, which produce proteins which also activate the same sort of pathways that are seen as a result of the gene mutations. In addition, there's chronic B-cell hyperactivation in people living with HIV, and this causes very driven B-cell proliferation, which puts the patients at risk of higher risk of developing deleterious mutations from somatic hypermutation and class switching. So that the pathogenesis of diffuse large B-cell lymphoma in people with HIV is multi-pronged. In people with HIV, diffuse large B-cell lymphoma is more likely to occur at an earlier age, with more advanced clinical stage, with a higher frequency of B symptoms, and in some instances, poorer outcomes. It's long been known that diffuse large B-cell lymphoma comes in two broad flavors, the activated B-cell and the germinal center subtypes. And this was originally demonstrated in gene expression profiling, but this is not very widely available for routine clinical laboratories. So we use the Hunt's algorithm to define the cell of origin immunohistochemically. Historically, the non-germinal center subtype was felt to be associated with poorer outcomes and perhaps meriting a treatment with novel agents. But this has not really played out in real-world settings as it did in clinical trials. And it has since emerged that actually the activated B-cell and germinal center B-cell subtypes can be further subdivided into several further subtypes. And this emerged in high throughput genomic sequencing studies. And in these subtypes, some of them may produce, for example, an activated B-cell subtype, like this one right at the bottom, where activated B-cell subtypes are possible immunohistochemically, but they have a favorable outcome. So going forward, this type of stratification may be more useful for prognostication. So the first part of the research I'm going to present to you is from this study that we did, looking at all of the lymphomas that were diagnosed in the Johannesburg State Sector Laboratories during the course of 2017. And for this particular paper, we looked specifically at the cases with diffuse large B-cell lymphoma. So there were 221 cases, and that made up about 38% of all of the lymphomas that were diagnosed at the time. The vast majority, over 85%, were diagnosed in people with HIV, and the median age was 42 years. The proportion of patients who had immunological AIDS was about 60%. About half of them were on antiretroviral therapy, and just over a third were virologically suppressed. The male to female ratio showed a slight male predominance, and the median CD4 count was just over 150 cells per microliter. FISH analysis showed a relatively high rate of MYC gene rearrangement and an absence of BCL2 rearrangements. The cell of origin was a germinal center cell of origin in 60% of cases. The LDH was abnormal in the vast majority, and overall survival rates were very poor, with a median survival of only 5 months and a 12-month survival rate of only 28%. Now, this is very much lower than international literature suggests for diffuse large B-cell lymphoma, where median survival times exceed 5 years. And this wasn't the first paper to have stemmed from South Africa about diffuse large B-cell lymphoma. There has been other work from Stellenbosch, from Cape Town, from KZN, and from my colleagues in the clinical hematology unit at Baragwanath Hospital, as well as from a group in Malawi that has done quite a bit of work. This group is headed by a team from the University of North Carolina, and they are the only ones, to my knowledge, to have published clinical trials in HIV-associated diffuse large B-cell lymphoma. There's a lot of common ground between all of these studies. There's alignment as regards to the median age of HIV-associated diffuse large B, which is between 40 and 45 years. Essentially, all of the studies showed a median CD4 count between 100 and 200 cells per microliter, and most showed a germinal center predominance. What was very different in our study was the larger proportion of HIV-associated diffuse large B-cell lymphoma as compared to what was seen in Cape Town, where under a third of their patients are HIV positive. And then our survival rates were really an outlier, very much poorer than those reported by even our other colleagues within the country, who reported median survival rates of more than 7 months, on average over a year, and 40 to 50% 2-year overall survival rates. The contributions that were novel from this study were the genetic results, which have not been widely published from South Africa. And it was no surprise that we saw higher rates of MYC gene rearrangements because of the high rates of HIV-associated lymphomas, which are known to be a risk for MYC gene rearrangement. But it was a bit of a surprise that we saw absolutely no BCL2 rearrangements, which are present according to the international literature in 20 to 30% of cases. And this speaks to the difference in the disease biology that we see here. And I think is probably also related to the very low rates of follicular lymphoma we see in our Black African population. Median survival was also noteworthy and an outlier worth commenting on. At the time, we attributed this to, or potentially to, the study's design, which included every case of lymphoma that was diagnosed that year, whereas most of the other studies only included samples that were patients, or only included patients who had made it to an oncology center and had initiated treatment of some sort. So our thought was that there's a number of patients who are lost in between diagnosis and that process of being enrolled into an oncology center. So I'm not going to go into a lot of detail about the treatment of diffuse large B-cell lymphoma because I think this audience would be more familiar with it than I am. But it's safe to say that gold standard first-line treatment for diffuse large B-cell lymphoma in most instances involves R-CHOP in some or other configuration, even among people living with HIV. With respect to prognostic factors in diffuse large B, these include patient-related factors such as the age and performance status, disease-related factors such as the clinical stage and the presence of extranodal disease, aspects of the disease biology such as the cell of origin and the presence of MYC gene rearrangement, and components of the tumor microenvironment. So generally in clinical practice, the IPI and the IPI is very widely used for prognostic assessment, and this includes patient-related factors and disease-related factors. Our histopathologists are also very good at further characterizing the disease biology for prognostic reasons, but the tumor microenvironment is entirely overlooked in terms of prognostic impact. So one of the components of the tumor microenvironment that is prognostically important is the number of tumor-associated macrophages. Macrophages come in 2 different flavors: a pro-inflammatory phenotype, so-called M1 macrophages, and a more anti-inflammatory phenotype, so-called M2 macrophages. M1 macrophages are produced in response to Th1 cytokines, and they produce pro-inflammatory cytokines like interferon gamma and interleukin-1 beta, as well as reactive oxygen species. Whereas M2 macrophages are produced in response to Th2 cytokines, and they produce more immunosuppressive cytokines like interleukin-10 and TGF-beta. So M1 macrophages serve as sort of soldier cells fighting infection and serving an anti-tumor function, whereas M2 macrophages function in wound healing and tissue repair to mop up after the soldier has finished his business. M1 and M2 macrophages also handle iron differently. On the left, M1 macrophages tend to sequester iron as ferritin, restricting its bioavailability to organisms and surrounding cells, whereas M2 macrophages take up iron via the heme uptake receptor CD163. They process heme within the cell by heme oxygenase, release iron, and actually release it to surrounding cells as ferrous iron, storing very little as ferritin. Now, what is also evident here is that the heme receptor CD163 is highly expressed on M2 macrophages, and this is how we can distinguish it from M1 macrophages. So the M1 pro-inflammatory macrophages play an important role in anti-tumor immune responses, as do cytotoxic T cells, whereas anti-inflammatory M2 macrophages have more of a tumor permissive effect. They do this in a couple of ways. First of all, they produce an enzyme called indoleamine dioxygenase, which converts tryptophan to kynurenine. And the resultant tryptophan depletion causes cytotoxic T cell apoptosis and the induction of regulatory T cells. They also produce interleukin-10 and TGF-beta, which further amplifies the differentiation of regulatory T cells. These in turn also make interleukin-10 and TGF-beta to further fuel this anti-inflammatory process. Interleukin-10 particularly has a pro-proliferative effect in tumor cells as it activates the JAK2 signaling pathway. Interleukin-10 and TGF-beta also encourage differentiation of macrophages and polarization to an M2 phenotype. At the same time, endothelial cells within the tumor microenvironment make interleukin-6, which serves as a B cell growth factor and stimulates differentiation of B cells towards plasma cells. The tumor cells also make cytokines like interleukin-6 and interleukin-10 to further contribute to changes in the microenvironment, which is permissive to themselves. In the course of natural inflammatory responses, pro-inflammatory macrophages tend to eventually become anti-inflammatory macrophages. This is a homeostatic process. So with the course of time, with prolonged inflammation, one anticipates to see more of an M2 environment than an M1 environment. Now, the prognostic role of macrophages in the tumor microenvironment in diffuse large B has been quite well established in both immunohistochemical and gene expression profiling studies, which have shown that high numbers of tumor-associated macrophages is associated with poorer outcomes. Some studies have actually also shown that patients who have high macrophage numbers have better responses to rituximab, and those patients with high macrophage numbers who are not treated with rituximab do worse, but if they're treated with rituximab, have a better outcome. And this is thought to be due to the fact that the macrophages serve as a target that can phagocytose the opsonized tumor cells. Other studies have suggested that the poor outcomes seen with high numbers of tumor-associated macrophages are due to high numbers of M2 macrophages specifically. So in this study, my hypothesis for my PhD was that underlying HIV could cause tumor enrichment of macrophage enrichment due to underlying chronic inflammation related to immunosuppression. And this might translate to a higher number of tumor macrophages in patients with HIV-associated diffuse large B-cell lymphoma. And that they may be M2 predominant because of sustained inflammation. And this may account for the poorer outcomes we sometimes see in people living with HIV. However, tumor macrophage enumeration is actually quite tricksy. It's a subjective process, it's quite laborious, and cell counting software is not really useful for it because the cells don't stain very homogeneously and they have variable size and quite large cells. And so it's really not, it doesn't lend itself readily to assessment in routine clinical practice or clinical laboratory practice. So working on the basis and on the hypothesis that we would find M2 macrophages to be associated with poorer outcomes, I looked for potential markers that could reflect their numbers. And importantly, there are a number of immune-related biomarkers which actually have shown to be associated with poorer outcomes in people with diffuse large B-cell lymphoma in other parts of the world, and which could theoretically mirror the tumor macrophage burden. These include high peripheral blood monocyte counts, increased numbers of immunosuppressive monocytes. These are monocytes which express unusually dim HLA-DR and are thought to be the peripheral blood counterparts of M2 macrophages. High peripheral blood Treg counts, high peripheral blood IL-6 levels or IL-10 levels, low peripheral blood TGF-beta levels, high peripheral blood kynurenine levels, which reflects increased IDO activity, high CRP levels, which is a pro-inflammatory molecule, may reflect macrophage activity, and high ferritin levels, which ferritin also having inflammatory links. None of these variables have been assessed in the setting of HIV-associated diffuse large B-cell lymphoma previously, and neither have tumor macrophage numbers. So the aim of the study was to assess the number and prognostic impact of M1 and M2 macrophages in diffuse large B-cell lymphoma in our setting, and to assess the levels, prognostic impact, and relationship to the tumor macrophage numbers of all of these variables that I've just mentioned in the previous slide. So how did I do this? I recruited 76 patients with newly diagnosed diffuse large B-cell lymphoma who were either diagnosed at or referred to the clinical hematology units at Baragwanath Hospital in Johannesburg. I then did the cytokine measurements using the Luminix assay. I measured regulatory T-cell numbers and HLA-DR low monocytes by flow cytometry. We measured IDO activity by performing kynurenine and tryptophan ELISAs and calculating a kynurenine to tryptophan ratio, which reflects IDO activity. We also looked at peripheral blood monocyte and lymphocyte numbers, which were measured on a routine hematology analyzer. We looked at tumor macrophage numbers by doing immunohistochemistry for CD68 and CD163, remembering that CD163 highlights M2 macrophages, whereas CD68 is positive in all macrophages. And then we collected relevant clinical and laboratory data from the clinical records. Now, as it happened, and at the time of the study was performed, which was between 2019 and 2022, rituximab use in the first-line therapy protocols of patients with HIV-associated diffuse large B-cell lymphoma was low. And so to further enrich the sample with patients who had received rituximab upfront, I enrolled a further 18 samples from a previous study which had been performed at Baragwanath, looking at the difference between patients who were treated with either CHOP or R-CHOP in HIV-associated lymphomas. So what were the results? So we had an HIV seropositivity rate of about just over 80%, median age of 42 years, very similar male to female ratio to what we saw in the original study, median CD4 count of 148, with about 80% of the patients on ARVs at the time, but with lower rates of virological suppression, only just over a third virologically suppressed. Most patients had advanced stage disease, a little bit more so in the HIV positive patients, but there was not a statistically significant difference between the HIV positive and negative patients. About half had a poor performance status, and just under 30% had an IPI of 4 or more. The cell of origin was a germinal center subtype in 75% of the cases and didn't differ according to HIV status. And most patients were treated with CHOP upfront, with very few receiving R-CHOP and even fewer receiving an alternative regimen. So including the patients who were from the other study who had received rituximab upfront increased the HIV seropositivity rate to 87% because all of those patients from the previous study were HIV positive. The parameters were otherwise very similar, slightly higher CD4 count, and a better performance status, relatively lower portion with a high performance status because there was some patient selection for that previous study. And here you can see that after including those patients, 28% received rituximab upfront. So the outcomes after a median follow-up of nearly 30 months was a median survival of 4 months and 12-month survival rate of 31.5%. Very similar to the previous study I presented to you, and this didn't differ according to HIV status. So before moving on any further, just to state that an IPI of more than 4 and a CD4 count of less than 150 were independently associated with poorer outcomes. So before I go any further, I just wanted to stop and delve into why we are seeing such very bad survival rates here in Johannesburg. This affected patients who were both HIV positive and negative, and there's almost certainly a contribution to this from very late patient presentation as a result of many factors, but at least in part due to the weaknesses of our health system. But in addition, looking more closely at the people with HIV well, before I say this, the very low median survival time was attributable to an extremely high early death rate, people who died within a month. 25% or more of the patients died within a month of diagnosis. 2/3 of these did not receive any chemotherapy. These patients dominantly died, well, the reason was unclear in nearly half of them, but those where a cause was identifiable died of sepsis and renal failure. And as I've just stated, some of them were HIV negative and had very advanced stage disease, late disease. But in the patients who were HIV positive, those who died early had significantly lower CD4 counts, higher viral loads, a lower proportion were on antiretroviral therapy, and those who were on treatment had been on treatment for a substantially shorter period of time with a lower rate of virological suppression. So we're talking about patients with more advanced and more poorly controlled HIV infection. But looking at the biology and disease characteristics, the LDH levels were very much higher in these patients, and there was a higher rate of MYC gene rearrangement or of extra copies of the MYC gene, which suggests that there is some difference in the biology of this disease and that perhaps there is a more aggressive form of the lymphoma, of diffuse large B-cell lymphoma, which affects patients with more advanced immune deficiency that we are seeing in these two cohorts and bringing down the median survival time. Okay, so moving on to some of the results related to my study. So we found that monocyte counts, the median monocyte count was not elevated and did not differ according to HIV status. The Treg numbers similarly were not, the median Treg number was not above a reference range, did not differ according to HIV status. The number of immunosuppressive HLA-DR low monocytes was above the reference range, but did not differ according to HIV status. Regarding these aspects, this is just an image of the flow cytometry of the immunodeficient or HLA-DR low monocytes, and you can see in the middle image are monocytes expressing very bright HLA-DR, and in the right image are monocytes with very weak HLA-DR. Regarding the relationship with these parameters to survival, neither the monocyte count nor the number of immunosuppressive monocytes had association with survival. The number of Tregs was associated with inferior survival on univariate analysis. Unfortunately, this could not be incorporated into a multivariate model, including the IPI and CD4 count, owing to a lack of proportionality of the data. In terms of the cytokine levels, interleukin-6 was very high in our patients, and that was in both the HIV positive and negative patients, but significantly more so in the people with HIV. Interleukin-10 levels were also very high, but didn't quite reach statistical significance in terms of the difference with HIV positive, between the HIV positive and negative patients. TGF-beta levels also looked very different between the HIV positive and negative patients, but this difference didn't actually reach statistical significance. Kynurenine levels were significantly higher in the people with HIV, as were the KT ratios. CRP levels were also very high in the majority of patients, was increased and significantly higher in the people with HIV. Again, median ferritin levels were high, but did not differ according to HIV status. Now, looking at how these variables impacted on survival, there was no relationship between IL-6 levels or kynurenine levels in survival, whereas interleukin-10 and ferritin levels were independently linked with poorer survival. The TGF-beta levels were interesting because the international reports have shown that low TGF-beta levels are linked with poorer outcomes. What we found was, in fact, high TGF-beta levels were independently linked with poorer outcomes. CRP levels appeared to be associated with survival in univariate analysis, but this was not independent of the IPI or CD4 count. And there's some Kaplan-Meier plots for you to have a look at. I'm noting particularly the IL-10 level on the top, which showed a very wide difference between those with high and low IL-10 levels in terms of survival. Looking at the macrophage data. So in terms of absolute macrophage numbers, it looked as if the number of macrophages was a little bit higher in the people with HIV, but was not significantly so. The number of M1 macrophages was very similar between the HIV positive and negative patients. M2 macrophages looked a little bit more enriched in the HIV positive group, and the M1 to M2 ratio looked a bit lower, but again, these did not meet any statistical significance. And here are some images, the top one showing a tumor enriched with macrophages and the bottom one with very few. Regarding the reports that pro-inflammatory M1 macrophages tend to become M2 macrophages, we saw evidence of this in that the higher the number of M2 macrophages, the lower the number of M1 macrophages. Now, regarding the number of macrophages and the link with outcome, so it's been reported that high macrophage numbers are associated with poorer outcomes. In fact, we found that was not the case. We found high macrophage numbers were actually associated with better outcomes. And this was independent of IPI and CD4 count. Looking at stratifying this according to whether it was M1 or M2 macrophages, we found that it was high levels of M1 macrophages, which is associated with superior survival independently, whereas high numbers of M2 macrophages actually had no impact on survival. And you can see that in the Kaplan-Meier curves below, where there is some difference in the cases with high M1 macrophages, but not with high M2 macrophages, high and low M2 macrophages. All right. So if you recall, I mentioned earlier that some studies suggested that the number of macrophages had an impact on how well the patients responded to rituximab therapy. So we had a little bit of a closer look at the rituximab therapy response. So just to start off with, comparing patients who received rituximab upfront versus those who didn't, there wasn't actually a significant difference in survival outcomes. However, when we looked at, because a number of patients who achieved a partial response to CHOP therapy, then were treated with rituximab later on as second-line therapy. So long as a patient received rituximab as first or second-line therapy, the outcomes were actually significantly better than those who didn't receive rituximab at all. So it would appear that so long as a patient gets some rituximab at some point in the course of their treatment, that is sufficient. All right. So looking now at the role of macrophage numbers in the response to rituximab therapy, these are patients who received rituximab up front. in relation to the number of macrophages, high or low macrophages, and you can see there was no significant difference in the response to rituximab therapy according to the number of macrophages. But again, in patients who had rituximab at some point in their treatment, patients who had high macrophage numbers responded better. Those who had low macrophage numbers didn't respond as well to rituximab. So again, it looks as if so long as there is some rituximab in the treatment and macrophage levels are high, the patient will respond well. So when we stratified this according to whether it was M1 or M2 macrophages causing this, both of them seem to play a role, but the M2 macrophage numbers seem to be more predictive of the response. You can see in the bottom graph the much wider Kaplan-Meier plots, suggesting that M2 macrophages have a greater role in this rituximab response. Patients who had low macrophage numbers didn't respond well to rituximab therapy in first line, second line at any point. So if macrophage numbers were low, the rituximab response was low. All right. In terms of all of those immunological biomarkers that we looked at, how did they compare to macrophage numbers? Well, all of them, the only one that showed any relationship to macrophage numbers was the serum ferritin level, which was inversely related to M1 macrophage numbers and positively related to M2 macrophage numbers. So in other words, the higher the number of M2 macrophages, the higher the ferritin levels. This is a bit odd because, as I mentioned earlier, M1 macrophages tend to sequester iron and ferritin, and we don't expect high ferritin levels in M2 macrophages. So this was a bit of an unexpected finding. However, it has previously been reported in the context of carcinoma of the breast, where ferritin expression by M2 macrophages was documented and associated with poorer outcomes. And it's also been reported that ferritin might help polarize macrophages towards an M2 phenotype. So it might be here that the M2 macrophage numbers are a product of high ferritin levels and not necessarily the source thereof. So quite surprisingly to me, not one of the other variables, nothing, CRP, none of the pro-inflammatory interleukin-6, none of those variables showed any relationship to tumor macrophage numbers at all. So looking a little bit more closely at the ferritin, which was the only variable that showed any relationship to macrophage numbers, we did show that ferritin levels were independently associated with outcomes. High ferritin levels at a level over 324 was significantly associated with significantly poorer outcomes. So we thought, okay, so if rituximab responses are dependent on macrophage numbers, and macrophage numbers are related to ferritin numbers, let's see what the relationship between the ferritin level and the response to rituximab is. So what we saw is that patients who had low ferritin levels didn't show a benefit from rituximab therapy. They did well anyway. Whereas those who had high ferritin levels showed a significant benefit from rituximab therapy, either first or second line. Okay, so to just take a second look at some of these things that we found. We found that a number of the variables that have been described internationally to have prognostic relevance were not prognostic in our setting. So amongst these included high peripheral blood monocyte counts, which were not linked to prognosis. Now, it's possible this is because of the low rates of rituximab use in our cohort, because monocytes, or patients with high monocyte counts, monocytes have been recorded to so-called shave the rituximab CD20 complex off of the surface of B cells, thus reducing the efficacy of rituximab therapy in people with high monocyte counts. So it's possible that the low number of people on rituximab in our cohort accounted for the lack of association between the monocyte count and outcomes here. That being said, we saw monocytosis in a similar frequency amongst the HIV positive and negative patients. But when we looked at did a bit of sub-analysis, we saw a much stronger association between the monocyte count and survival in the HIV negative patients. So it does look as if there is perhaps something that is a bit different in the HIV negative group as compared to the HIV positive group. And we speculate that the source of the monocytosis, it differs according to HIV status. So HIV negative people, the monocytosis is more likely to be a paraneoplastic phenomenon as a result of cytokines produced in the tumor, and therefore reflect something of the disease biology. Whereas in people with HIV who have a monocytosis, that may be more likely to be related to an underlying infective process, and therefore less representative of the tumor biology, and therefore less representative of how the tumor will behave. High numbers of immunosuppressive monocytes were also not predictive in this study, while the number of peripheral blood regulatory T cells was unfortunately unclear in terms of its prognostic impact. High peripheral blood interleukin-6 levels were also not associated with outcomes. And we know interleukin-6 serves as a B cell growth factor, activating JAK2 signaling within B cells. And in previous studies, the IL-6 levels have been shown to be linked with markers of disease bulk, such as bulky disease and advanced stage disease. And we didn't see that link in our cohort. So again, we speculate that this is not, the interleukin-6 in people with HIV is not only stemming from the tumor, but also from infective sources, and then it therefore is less representative and reflective of the tumor biology, and therefore less reflective of how the tumor will behave. High peripheral blood levels of interleukin-10 was found to be, or were found to be significantly associated with poorer outcomes. So interleukin-10 activates JAK2 signaling within B cells, and so is the B cell growth factor. And you can see in the Kaplan-Meier plot here that it was quite a dramatic difference in outcomes in relation to interleukin-10 levels. So in addition to being a B cell growth factor, IL-10 also recruits regulatory T cells to the tumor microenvironment, and that might account for the very poor outcomes we saw here. And it's notable that there are a number of preclinical studies underway which are assessing inhibition of interleukin-10. These include JAK inhibitors and monoclonal antibodies directed against interleukin-10. And such therapeutic agents may be of interest and may be of benefit in our clinical setting. Low peripheral blood levels of TGF-beta were not found to be associated with outcomes here, rather, or inferior outcomes. It was high TGF-betas that were associated with poorer outcomes. TGF-beta has pleiotropic effects, and one of these includes they are more B cell suppressive and cause reduced B cell proliferation. And that's presumably why in international studies, low levels of TGF-beta have been associated with poorer outcomes. However, TGF-beta is also linked with a lot of immune effects, including induction of regulatory T cells and M2 macrophages, as well as other changes to the stromal components of the tumor microenvironment. And it's presumably one of these factors that has the negative impact, perhaps relating to the number of regulatory T cells in our patients. And in fact, this has been described in the setting of follicular lymphoma, where the expansion of regulatory T cells was associated with poorer outcomes in patients with high TGF-beta levels. Another interesting thing is that it has been recorded that some lymphomas become desensitized to TGF-beta due to capping or the absence of TGF-beta receptor expression on these tumor cell surfaces, particularly in EBV positive neoplasms. So if there's no TGF-beta receptor, the tumor cells won't respond to high levels of TGF-beta. And it's notable that this occurs due to epigenetic silencing of the receptor, and the receptor expression can be partially reversed, and the epigenetic silencing of the receptor can be partially reversed by the use of epigenetic modifying agents, demethylating agents. So the exploration of such a strategy may also be worth pursuing in our context. High peripheral blood levels of kynurenine were also not linked with outcomes, and that's likely also due to underlying HIV infection. This is a list of previous studies that have demonstrated high kynurenine or low tryptophan or high IDO activity in people with HIV without lymphoma. So this is, again, more likely an HIV phenomenon rather than a lymphoma phenomenon and not representative of the tumor biology. High CRP levels were also not linked with outcomes, likely for the similar reasons that we've discussed for interleukin-6, monocyte counts, and so on. High ferritin levels were also independently associated with poorer outcomes. Now, ferritin is known to have antioxidant effects in the tumor microenvironment and thus protecting tumor cells from reactive oxygen species. And it is postulated that one of the mechanisms whereby chemotherapy causes cell death is to increase the generation of oxidative stress in the tumor microenvironment. So ferritin could be partially protective from this, causing a degree of chemoresistance. And lastly, we did not find that high M2 macrophage numbers were associated with poorer outcomes, rather that poorer outcomes were associated with low M1 macrophage numbers. Now, this was not the first study looking at macrophage numbers in people living with HIV. There was one previous study from 2015, and they found, like we did, that there was no significant association between macrophage numbers and HIV status. But they also recorded that there was no significant association between macrophage numbers and survival, although they did note that patients who had very low macrophage numbers had particularly poor outcomes, but this was not statistically significant. So we found that it was low M1 macrophages and that the presence of low M1 macrophage levels was associated with
Oh, no, now look at that on the roof. Look at what they look like.
So,
sorry, if who's ever unmuted, if they could possibly mute.
it looks like they have now.
Thank you.
So this speaks to a dominant role for pro-inflammatory M1 macrophage activity in tumor control in HIV-associated diffuse large B-cell lymphoma, although it has to be said that the negative impact of M2 macrophages might be countered by the positive response to rituximab that these macrophages seem to confer. It's also interesting that there are preclinical studies underway which are looking at how to manipulate the tumor microenvironment to promote repolarization of M2 macrophages back to M1 macrophages. These include interesting strategies like giving intravenous iron and various pro-inflammatory molecules to try and stimulate a pro-inflammatory M1 response again. And such a strategy might also be of interest in our setting. Regarding macrophages and rituximab therapy, we saw no clear benefit from rituximab therapy in the index chemotherapy regimen, but that patients who had rituximab at some point in their treatment had superior outcomes. Patients with high numbers of M2 macrophages seem to show an improved survival if rituximab was received at all. And this is explained by a previous study which showed that M2 macrophages had greater phagocytic capacity for rituximab opsonized leukemic targets. So it would seem that the M2 macrophages make sense because they are those cells which mop up and phagocytose and clean up things very nicely. So they are more likely to phagocytose rituximab-coated cells. Regarding ferritin as a biomarker of macrophages in the tumor microenvironment, we showed that ferritin levels were marginally associated with both M1 and M2 macrophage numbers, that patients with low ferritin levels showed no benefit from rituximab therapy, and that patients who had high ferritin levels had significantly better outcomes if they received rituximab therapy. So theoretically and potentially, we could reserve rituximab therapy for patients with high ferritin levels in the resource-constrained environment, potentially improving outcomes in patients with high ferritin levels, and also potentially improving their outcomes if we gave them rituximab earlier in their treatment course. So just to conclude, we found that a number of the variables which are associated or linked with prognosis in other parts of the world were not associated with outcomes in HIV-associated diffuse large B-cell lymphoma. But important factors included high IL-10 levels, high TGF-beta levels, high ferritin levels, and low macrophage, M1 macrophage numbers. We found that high M2 macrophage numbers were associated with improved responses to rituximab, that ferritin is a modest biomarker of tumor M1 and M2 macrophage numbers, which is, as we all know, widely available and not an expensive test, and that high ferritin seems to be a relatively good biomarker for predicting a likely benefit from rituximab therapy. However, I have to say that this needs to be verified in future studies. I'd like to thank you all for your attention and also to particularly acknowledge my supervisors, Dr. Tracy Wiggle and Prof. Patel, the clinical hematology unit at Baragwanath Hospital for all of their help with patient recruitment, for a number of people who helped me with the technical aspects of the study, and for my funders, and lastly to all of the staff members of the laboratories in Johannesburg, which are so critical for the diagnosis of diffuse large B-cell lymphoma. And thank you all for your attention, and I'm very happy to take any questions.
Thank you for that very interesting talk, Jenny. So I'd like to open the floor for questions. If anybody wants to ask anything, if you could perhaps type it in the chat for me, or alternatively, I think you could unmute and ask your question and give everybody a moment to see if anybody has any questions. Okay, well, maybe in the meantime, while we're waiting to see if anybody is typing something, can't see anything in the chat at the moment. Perhaps if I could ask Jenny, and it's more an open-ended question because I don't really think we know the answer, but perhaps even for input from the floor, what people think. But my query really relates to what the effect of COVID, underlying COVID infection and persistence of COVID infection with long COVID has, or what we think it might have on lymphoma incidence moving forward, because we do know that COVID was associated with a lot of immune dysregulation, both of macrophages and of B cells with some autoimmune complications, and the thought that long COVID might have some kind of an inflammatory component. So I'm not sure if anybody's looked at anything. Has there been anything in the literature? If anybody in the audience maybe wants to also suggest, what do we think, or do we think COVID would have an effect on lymphoma incidence in the long term?
Thanks, Trace. That's a really interesting question. And I think, as you said, I don't know the answer to that. I think that that is something that we'll see play out with a bit of time. And certainly if we see lymphoma in patients with immune dysfunction, HIV, autoimmune diseases, and so on. So it would certainly be logical that patients with long COVID, many of the complications of COVID may be at increased risk of lymphoma going forward, but I'm not aware of any reports of this, of an emergence of this at this point.
I think the problem also is that it's difficult to know what's actually just coincidental and what may be a definite thing and what is just a coincidence. So I suppose time will really tell. Okay, maybe if I can move to some of the questions in the chat. So I don't know if anybody wants to unmute and ask, or if you're happy for me to ask your question. Can I ask, or Jacqueline, do you want to unmute and ask?
I'm happy to bite. There's my. I also tried to put on my video.
Okay, thank you.
Yeah, so it's brilliant. Jenny, beautiful work. I think it's this whole microenvironment. I think my first question to you would be, what would you want to do next? Do you have other plans, or would you want to go more in a different area? Would you want to work more in the microenvironment?
Thanks, Estelle. Yes, I think that the findings from this study relating to ferritin are of great interest to me, and I think that is worth verifying going forward in a future study, at least at the very least to verify the prognostic relationship and the relationship with the rituximab response. I think I'd be interested to make sure that those findings are very valid. And then the next avenue that we are pursuing at this point, and specifically in my PhD patients, is we're wanting to do some next generation sequencing on them to try and look at tumor microenvironment signatures in terms of the molecular testing and genetic events in these patients, to try and tie this all together with the microenvironment a little bit further. So that's where we see ourselves going from at this point.
I think I also have a question regarding ferritin, and I would like to know if there's other colleagues who also have some impressions. We also think the ferritin is very interesting. I'm definitely no expert on the whole interrelation. I think mine is very observational. There has been some work done by, I don't think he's in the meeting, David Richardson, because he's was actually in another meeting just before this. But so he will have his own work on more on marrows, which will say something about some lymphoma patients. But I think my impression would have been that I'm not quite sure what cutoffs you used, because we often see incredibly high cutoffs, incredibly high ferritin, and the impression would be that it's associated with HIV patients. That's the impression. And it's also the impression that it's associated with bone marrow, for example, say Hodgkin. I cannot really make any remark on. Obviously, bone marrow DLBCL is a very advanced stage. It's actually usually very bad news for a patient. So it's a totally different situation. So don't you think there may be a kind of I don't know what you would call that, two kind of effects, very high ferritin, perhaps connected with poor outcome. Where would that cutoff be? And I think the fact that you think that a low ferritin could be associated with poorer response, I find that very intriguing, and I would like to hear what other colleagues would say about that, if they have also wondered, or do they regularly test ferritin? You are speaking of serum ferritin. It's always
yes.
Not speaking of bone marrow, because it's obviously serum ferritin, and then there's also what David looked at, and I'm sure there's others in this meeting that have looked at the marrow ferritin, but that's now not tumor tissue in the DLBCL. It's usually simply staging marrows. It's got nothing to do with the tumor itself.
Okay, just one point to clarify. So patients who had low ferritins, they didn't show a benefit from rituximab, but they had positive outcomes. They had good outcomes. So just to clarify that low ferritin was not linked with poor prognosis. It was just that they didn't.
Sorry.
Yeah, they didn't need rituximab. They did just as well without rituximab.
Oh, wonderful. That's very interesting.
So regarding the cutoff, so I established the cutoffs for all of these parameters using ROC curves at the point between patients who died and the patients who survived, using that as the cutoff point. So the cutoff turned out to be 324. So it's not dramatically increased ferritin. So not in the sort of HLH ballpark that we see in the sort of more Hodgkin context, as you've mentioned. So I don't really think that is massive role player. Secondly, the ferritin levels were actually similar in the HIV positive and negative patients. Was increased, the median ferritin was increased in both, and there was no significant difference between them in the HIV positive and negative patients. So it seems to be more related to disease biology than HIV.
Okay, so it was good if it was less than 324. That was...
Yes. Patients did better, and they didn't really need it appeared that they didn't need the rituximab. They did well anyway.
And so people showing benefit from rituximab would sometimes have had higher levels.
Higher ferritins, yes. So we
Okay.
speculate that that's because they've got higher numbers of these M2 macrophages in the tumor, and then they respond better to rituximab.
Okay. Okay. So I hope that if you do genomic work, that you could tie it back to your microenvironment. That's probably
Yes, we really would
very
like
nice.
to.
Yeah. I don't know what others have thought about the treatment of these patients. It definitely is late stage, it's like the elephant in the room, isn't it? Also
Mm.
from the results you show, it's the late stage that is often the early death that causes early death.
This is true. Seeing Jägerlin has commented on turmeric shots from a major retailer, which represses the synthesis of hepcidin and can affect ferritin. It sounds really interesting, Jägerlin. I'm not aware that any of our patients had such a thing, but it sounds like something that would be worth looking further into. Moses, you asked if we did serial levels of the interleukins. Unfortunately, that wasn't possible, both from just the logistics and cost aspect, predominantly for that reason. I think, and Garrick's responded to that, and perhaps going forward, monitoring ferritin levels might also be of interest. I'm not sure. Thank you to Garrick for his kind comments.
There are quite a few comments saying
thank you to everybody.
Just one more question. You do, I'm sure, because you've got an excellent pathology department, and there is also wonderful work, I'm sure, happening at pathology on DLBCL from their side, which I must confess, I haven't recently, read specifically, gone to read all the different things they did, but they will do EBV.
Yes,
that will be
in the study, actually, it was really not performed very regularly at all. In the previous study, the one that I presented from 2017, I think they did it in only 12 of the 221 patients, was positive in 4 of the 12. In this cohort, it was hardly done at all. So it's a bit of a...
It is now actually very important for...
It is. So just bearing in mind that the latest 2022 guideline has included the assessment for underlying oncogenic viruses, but it wasn't part of the 2017 guideline, the WHO. It was sort of more recommended in people who are HIV negative, where you could make a diagnosis of EBV-associated diffuse large B-cell lymphoma, but you actually couldn't make that diagnosis in people with HIV. They were excluded from that diagnosis. So that might have been why there was low uptake of the stain. It didn't really make too much difference. But going forward, that is included in the 2022 WHO recommendation. So I'm sure we'll see more data coming out of that going forward.
Okay, so you don't have an NGS panel yet at WITS for lymphoma?
No, that's in the pipeline.
And doing a regular, I mean, you did show very nice data on your MYC and
yes.
BCL2 and BCL6, very interesting. So that, but I can't remember now, they were done not necessarily by FISH, they could also have done by expression. I can't remember if it was expression.
No, so those were done by FISH for the translocation. So just remembering that immunohistochemistry shows the expression, but these were evaluating the gene for gene rearrangement. So our histopathology department, they do it, and they're pretty good at doing the FISH in diffuse large B-cell lymphoma.
So, and if you say the FISH, because that's sometimes the problem.
Okay, so they usually start off with a MYC gene rearrangement or an 814, and if it is positive, then they screen further for a double hit BCL6 and BCL2 rearrangements.
Okay, so they still do that, but I'm sure, again, I'm not the one thinking, but you do wonder if that won't change with subsequent.
Yes. So the new WHO is now saying that they don't actually recognize BCL6 as a double hit with MIC. That's actually almost universally what we see as double hit, and the double hits we see do very badly. So even the WHO does make allowance to document BCL, a DLBCL NOS with MIC and BCL6 rearrangement. They just don't classify it as a double hit anymore. They just make note of it. And whether these things actually translate to a change in treatment is not entirely clear, but I think we have been able to show that it is helping us for academic purposes and in elucidating what is bad in our population.
Yes, strangely enough, we don't find many of the double hit because we have been infrequently doing these
Yeah.
Speaking of, we are trying to do more. Perhaps it will change. I don't know if there's anybody else in the meeting that, that saw the test that Jenny did and, wondered if it was different or the same of these. I don't know.
Well, I mean, I got to say that it feels a bit like Johannesburg and Cape Town are in different countries, because just looking at the rates of HIV-associated diffuse large B-cell lymphoma is so much lower. The literature suggests that you have more Burkitt than we do, whereas diffuse large B is our most common lymphoma. There's so many areas that we seem to lack common ground.
I think it would be great to look at it all again once when we have time. North, south.
That's something I've also thought about a lot, as to why the picture between Joburg and Cape Town and maybe some of the other centers is so different, because it isn't. I mean, generally the international literature suggests that Burkitt's remained stable or even went up after the start of ARVs, but Joburg had the kind of opposite picture, where Burkitt seems to have gone down and diffuse large B seems to be at least stable or actually increasing. Comparatively speaking, which is different, I think, certainly also from international data.
Well,
and
Tracy,
seems
I
to be
think
different from yours.
You've published more than we have. I think that may be the point. I think we also see, and I see Cecilia's also in the meeting, I think we also find that Burkitt is definitely not more, perhaps even less HIV positive Burkitt. I don't think we see more, we see less. Cecile, agree?
Yeah, I think it's slightly less. There was a time we were overwhelmed. The ward was literally full of Burkitts. We're not quite seeing that anymore. And we are seeing our share of diffuse large B. We do particularly poorly. I mean, we have a lot that are refractory, and we have yet to salvage one successfully and get to transplant, even one.
Yeah, so it may not be that different, but I definitely the high percentage, I think, what was it, almost 80%, Jenny, with HIV positive.
Over.
Yeah, so that is very different. But the best way to see would be to just get all our, the problem to actually compare proportions is that you have to have the whole lot. So we've been laboring away for many, many years, Tracy. Perhaps we may be able to show it soon.
Yeah.
I think it will be great to compare between provinces and centers and put our heads together and see, these extra tests we do, what's the difference, and also what we can glean from a research like Jenny's, what we can do differently or look at collectively, collaboratively.
Agreed.
I don't know what other people's experience has been, but I certainly thought from Joburg's side that the double hits kind of lymphomas had decreased as well. I don't know what your thoughts would be, Jenny, and maybe from the clinical guys in Joburg, what their findings have been, but I don't think we were seeing as many as we were at some stage.
Bit difficult to say. We don't see dozens of them. So
now just to write down is like, he's like between
Dr. Philip, did you want to say anything about your experience with double hits? if he's still on the call.
Thanks, Jenny, and thanks for an excellent talk. We are seeing double hits, but we are not really seeing that many, and I'm not sure. I really haven't looked at it carefully, so I can't tell you anything, but my feeling is we're not seeing as many as the literature suggests. And I was just thinking about the Burkitt numbers of patients with Burkitt lymphomas, and I think they actually may not be getting to hospital or getting to a center where the diagnosis is made, and they are probably dying before they get to hospital because they're such high-grade tumors. They go into tumor lysis, and people think it's more likely renal failure from HIV or something and miss the diagnosis completely. That's my feeling. Because when we get them, they're coming to us extremely late as well. But sorry, no comments on the double hit. I haven't looked at it carefully enough.
I think that we don't see a massive number of them, so it's a bit difficult to say if they're going up or down. But in my anecdotal observation, the double hits are very aggressive and they die quickly.
Just give everybody a chance to see if anybody else would like to make a comment or ask a question. A lot of people saying thank you for the talk. And Vanitha saying she'll consider doing a ferritin level after 6 months of therapy. That might be very helpful. And otherwise, I don't see any questions. Anybody got a last question that they would like to ask? Okay. If not, then I think it just remains for me to thank everybody, for Blood South Africa Foundation for inviting us, and to Jenny for the very interesting talk, and to the audience for attending, and for all the very interesting discussions and questions. Thank you very much, everybody. And
Thank you very much, Tracy, for chairing. It's great to have you.
Thank you, Trace.
Okay, thank you very much.
Great
Thanks,
work.
everyone.
Yeah.
Thanks so
Have a
much,
good
everybody.
afternoon.
Have a good rest of the day. Thanks a lot.
Thanks, everyone.
Okay, bye.